Good evening, everyone, and welcome to today's webcast, Psoriatic Arthritis Flare Management. My name is Corinne Pettit, and I will be your moderator for tonight's presentation. Before we get started, I would like to go over a few items so that you know how to participate in today's event. We've taken a screenshot of the Attendee Interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer speaker system by default. This means that if you can hear music through your computer, you should be able to hear the presentation. If you'd prefer to join over the telephone, just select Use Telephone in the audio pane, and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing into the questions pane of the control panel. You may send in your questions at any time during the presentation, and we will collect these and address as many as possible at the end. Before I introduce today's speaker, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. The National Psoriasis Foundation is the world's largest nonprofit patient advocacy organization dedicated to psoriasis and psoriatic arthritis, and we serve as the voice of millions of Americans who are affected by these diseases. Our mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. One way we improve the lives of those with psoriatic disease is by offering our Patient Navigation Center. Whether you've been newly diagnosed or have lived with your condition for years, our team of experts can help you find healthcare providers, discuss treatments, and get help with insurance. We'll work with you one-on-one to support your journey towards a healthy life. In order to move this mission forward, we engage thousands of volunteers around the country in activities that will lead to a cure. For more information about these opportunities, you can log on to our website after today's presentation at psoriasis.org. Next, on behalf of the National Psoriasis Foundation, we want to extend our thanks to Mallinckrodt Pharmaceuticals for their sponsorship of today's educational webcast and for making this presentation possible. Now I would like to introduce our guest speaker, Dr. Philip Meese. Dr. Meese is clinical professor of medicine at the University of Washington School of Medicine and is director of the Rheumatology Clinical Research Division at Swedish Medical Center in Seattle, Washington. Dr. Meese received his undergraduate and medical degrees from Stanford University in Stanford, California. He completed residency in internal medicine and fellowship in rheumatology at the University of Washington. Dr. Meese is a leading researcher and educator on disease state and treatment of rheumatic disorders. His research focuses on emerging therapeutics and outcome measures for clinical trials. He has served as principal or co-principal investigator on numerous clinical trials in RA, PsA, and AS, and has authored over 300 articles, numerous abstracts, and book chapters on these and related subjects. He serves on the review boards of the Journal of Rheumatology, Annals of the Rheumatic Diseases, Arthritis and Rheumatism, Arthritis Care and Research, Seminars in Arthritis and Rheumatism, and other leading publications. Dr. Meese is past president and founding organizer of the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, also known as GRAPPA, a member of the Assessment of Spondyloarthritis International Society, also known as ASAS, and the Spondyloarthritis Research and Treatment Network, known as SPARTAN. He is co-chair of the PsA Task Force with the National Psoriasis Foundation. Dr. Meese has been active in the outcome measures in rheumatology clinical trials research organization as co-chair of the PsA and chronic pain working groups. He conducts disease state research in registries such as the Consortium of Rheumatology Researchers of North America, also known as Corona, for which he is director of the Spondyloarthritis and Psoriatic Arthritis arm of the registry. Dr. Meese is a recipient of the American College of Rheumatology's Medical Communications Award. We are very happy to have him here today. Welcome, Dr. Meese.
Thank you very much, and thanks for having me on. Next time we'll have to figure out a way of shortening that that introduction so that we have more time for the presentation. So thanks, that was quite something. So I'm going to be talking about or focusing on the whole issue of flare of disease today, and particularly in relation to psoriatic arthritis. So that's going to be an interesting perspective for those of you who have psoriasis and psoriatic arthritis and do experience from time to time flare, which is a worsening of the disease, either transiently or more persistently, which is something that can certainly happen. So first we're going to talk about a little bit just about the disease itself, the frequency with which it's seen, some of the clinical features, and then we'll get into the weeds about flare management considerations, the role of stress, and some of the more recent research in this area. Psoriatic arthritis is an inflammatory form of arthritis. That's the key point here about the disease definition. The patients are often presenting in their younger years, 20s, 30s, 40s, 50s, long before the condition degenerative arthritis, which is the more common form of arthritis in humans, begins to occur in people's 50s, 60s, and beyond. An inflammatory arthritis implies that there's something wrong with the immune system. There's an overactivity of immune cell regulation that leads to the changes that you see in the skin that constitute psoriasis and the nails of psoriasis, as well as the arthritis and associated conditions which include enthesitis, wherever ligaments or tendons insert into bone, especially near joints, dactylitis, where there's almost like a sausage change of a whole digit, and spondylitis, where inflammation and pain occurs in the spine. The arthritis can present in quite different ways in different people, and it's often involving many joints, but in some people it can involve just a few. And in rare cases, there can be a mutilating variant where the far ends of the fingers or toes may be quite deformed. We know from a recent study, very carefully done in the U.S. population known as the NHANES study, that approximately 3% of the population of the United States has psoriasis, so 3 out of 100 people. We know from other studies that up to 30% of people with psoriasis will have psoriatic arthritis sometime during their lifetime. Most often, the psoriasis occurs many years before the arthritis condition, sometimes or roughly on average about 10 years. But in some cases, the arthritis may occur simultaneous with the onset of psoriasis, and confusingly, in some cases, the arthritis may even precede the appearance of the psoriasis condition. We know that patients with a family history of psoriatic disease, either psoriasis or psoriatic arthritis, usually have an earlier onset of psoriasis, more difficult to treat disease, and longer duration of disease, all of which may increase the risk of psoriatic arthritis later in life. Let's talk about flares of disease. So first of all, what's the baseline like? So many people with arthritis that's not yet treated will have persistent pain in several joints, the adjacent entheses or enthesitis, where tendons are inserting into bone, or in the spine. And so the patient will present with ongoing pain in these joints. Oftentimes they'll describe stiffness in the morning. And I call this the 10-man or 10-woman syndrome. So if you remember when in The Wizard of Oz, when the Tin Man starts to get oiled and then starts to loosen up, that's what I think of as stiffness, and that's a prominent feature. So pain, stiffness. Another common feature of the condition is fatigue. So this fatigue that's partly due to inflammation as well as having poor sleep and sometimes depression. So these are the sort of ongoing symptoms. Now, flare may be defined in different ways by different people, but it means a worsening or increase of pain, increase of stiffness, increase of fatigue, malaise, sleep disturbance. Some people call it like a flu, and sometimes the person can even tell before the flare starts that they're about to go into a flare. And these may last for days or sometimes weeks. And when it lasts beyond weeks, then we know that the whole disease process has increased in activity, and we may need to do a more major change in therapy. But there are a number of things that we can do short term to try to reduce the flare symptoms, which we'll get into in a little bit later. Now, sometimes flare just comes out of the blue. There's nothing that we can identify or the person can identify that seems to be related to the onset of the flare. But there are also a bunch of triggers, and those are listed here. Sometimes it could be weather change, and it's not unusual for us to hear patients say, well, gee, doc, if I move to a warmer climate or a climate where there wasn't as much change in weather, might I feel better? Stress can sometimes bring on a flare. That's very common, and it's hard for us to avoid stressful situations in our life. So this is something that, although we try to reduce as much as we can, sometimes it can't be reduced. Sometimes medications may actually bring on a flare. And an ironic example is use of cortisone-type medications or steroids. So, for example, if we're using prednisone for whatever reason, let's say that the person also has asthma, and they go in to the ER with an asthma flare and get some steroids for treating that. Then when the steroids are tapered off, we know that there can be a flare of psoriasis, and so that would be an example of a medication causing a flare. Overexertion can sometimes do it, although I think that I don't want to overemphasize this because in general we like very much for people to be exercisers, and so I don't want to overemphasize that. But if you, let's say, were in a marathon or something like that, it wouldn't be too surprising if for a few days you had increased symptoms. Infections are a real known cause for flare. And in the skin, we know that strep or staph infections of the skin can sometimes lead to a flare of psoriasis. We know that viral conditions can sometimes lead to a flare of psoriasis or psoriatic arthritis. Diet, we'll get into that a little bit more, but one of the things that we're going to be emphasizing is the importance of a balanced diet in order to both reduce weight and reduce likelihood of flare. Poor sleep, insomnia, stressful tossing and turning can lead to a flare. Smoking can do so, and trauma to the body can also do so. Now, in a study that was conducted in England by Philip Hellewell's group, here's a quote from the article about that study, and they're interested in studying flare and how patients describe flare. So here's the quote. We had considered that a relationship between peripheral disease flare, skin disease, axial, meaning spine, disease, and other aspects of flare might have emerged. But although one patient noted that a joint flare would always be preceded by a skin flare, we did not have enough material to explore this further. What they mean by that last phrase is it wasn't at all consistent, that there was any rhyme or reason that a skin flare would be followed by a joint flare or vice versa, and sometimes the two don't even go together. So it's important for you to recognize that the skin and the joints or the spine don't have to travel together. So here in this flow diagram, on the left-hand side, you've got the box that says triggers and management of pre-flare. What that means is that some patients will know what brings on a flare, like stressful situations or infection, and so they jump to the job of trying to reduce the likelihood that something like that will lead to a flare of their disease. And then all the other triggers that we talked about, and then remember what was also said, that sometimes there's nothing that really is an indicator that a flare will occur. It just happens. So then a bunch of things are in the cascading results of that, including an increase of physical symptoms like pain, stiffness, skin problems, itching, fatigue, sleep disturbance. Then there is the social consequence, which is the patient just kind of feels like they need to withdraw into a safe and warm place and not go out as much, not be with family as much, reduce enjoyable activities because they're just feeling crummy, like having the flu. There may be psychological symptoms like a feeling of depression or feeling out of control because you can't do work the way you would like to or enjoy social things. We've already spoken a lot about fatigue and loss of normal function. You can't get up and down stairs as well. You can't go out and mow the lawn or ride a bicycle. And that all of those things then lead to a desire to manage the flare in various ways, which we're going to come to in a moment. And down at the bottom, there's a box that says timing of flare, and this can really vary, as I mentioned earlier, ranging from days to weeks to months. And if it gets beyond that, then we think that the disease has gotten kicked into a higher gear and needs more substantive treatment. So here are some of the points that we just made. Some of the physical symptoms include pain and stiffness. Swelling of joints may occur. Heat. When you put your finger over a swollen and inflamed joint, it may feel hot. And then withdrawal from social and work activities. And this is accompanied by some of the psychosocial features, including depression, frustration that you can't do what you want to do, embarrassment about skin manifestations, fear that you don't know when it's going to settle down and you're going to get back to normal. And again, the point of fatigue, described in various ways, ranging from things like flu-like to extreme tiredness to no energy. I've just hit a wall, is what people often say. And then loss of function. That means loss of independence, loss of movement, increased dependence on others, loss of hobbies, work, and so forth. And here's a quote from a patient. I couldn't function. I couldn't function at all. And I'm used to being active and doing lots of stuff. And then I couldn't do anything. I hardly left the house for months. So that's a real problem if that's happening. And we would, as physicians, really want to know about this as soon as possible so that we can try to help the person diminish the flare. So let's move into talking about how we approach management. And on this slide, there are shown a grocery basket with lots of good food items in it. You see some tennis shoes on the upper right-hand side, and then we're going to get into everything ranging from proper footwear to use of braces, and also that might signify pacing activity to control what you would your normally overpaced life activity and controlling it to something more appropriate. Down below we see a pill bottle signifying use of medications, and then I love that the picture on the lower right, which is an old-fashioned kind of thing that you use to put either ice water in or hot water in and put it on an inflamed part of your body. these days we've got other kinds of things like heating pads or these various gel packs that you get in the drugstore that by activating them they become either hot or cold, and so these can be soothing or comforting for inflamed joints. Initially applying cold, but once it's been there for a day or so, then beginning to apply heat. So in terms of diet, what are some of the things that you can be doing? So here I mentioned a variety of things, including decreasing fatty food consumption, decreasing alcohol consumption, incorporating fish into your diet. There's not a lot of evidence for some of this, but the basic point is eating regularly, eating a healthy and balanced diet that's good for you. I think the diminishment of alcohol is really a good overall recommendation. And we also know that if we are on a healthy, balanced diet that allows us to lose weight, then there's been studies, for example, one that was done not long ago in Italy, where patients went on a very controlled diet, were able to lose at least 10% of their weight, and it turned out that they were better able to respond to treatments, medication treatments, and better able to achieve more lasting low disease activity state when they had managed to lose some weight. Exercise. Well, some people think, oh, gee, I should just go to bed and lay low, and that's going to be the best thing for me. But actually, that may not be the best thing. And so one of the things that we do encourage is modest activity. Doing some walking, maybe even once the flare begins to subside, getting back into regular exercise. Here are a few key points, including starting slow, doing stretching when you're exercising, choosing low-impact activities like swimming, cycling or walking, and actually one of my favorites for a person with arthritis is to recommend swimming. I know it's a catch-22 if you have active psoriasis and you're feeling a little embarrassed about being in a swimming suit. But if that's not a deterrent to you, one of the best things that we think people can do for themselves is going swimming. And then I would strongly have you consider one of the movement types of techniques like yoga or Tai Chi. I happen to be a regular practitioner of yoga myself. I've been doing it on a regular basis with my wife for about the last 9 years. We go regularly to classes. And I'm sure that as an old guy, I'm the worst person in the class, no question about it, in terms of stiffness and being able to move, and I don't even have much underlying arthritis. But it's really a good way for me to stretch muscles, tone muscles, and has helped prevent flares of neck or back pain due to my deteriorating joints in the spine. So I think it's something that I strongly recommend for the psoriatic arthritis patients that I see. And then here's a list of medications to talk through, and I'll take a little while on this particular slide just to talk about some of the pros and cons of these various medications. Let's presume that you're already on some kind of background medication for your psoriasis and psoriatic arthritis. Let's say that you're already on a medicine like one of the new anti-TNF medicines or the biologics that you inject yourself or something like that. So despite being on these great new medicines that have really revolutionized our ability to control the disease, it's inevitable that from time to time flares will still occur, especially if some of those triggers have managed to break through and cause a flare. Hopefully it will be shorter lived and less intense than it might have been without those medications being on board. And sometimes these medicines do wear off in their effectiveness. and even after years of treatment, the drug may not work as well, and having more frequent flares that are longer and longer in duration and severity may be a sign to us as physicians that this is that the drug is now not working as well, and we need to consider doing a switch of this background med. So then a lot of my subsequent comments are going to be in that context. The other context is for you, those of you that may be listening that are not on such a background disease-modifying drug. My comments will be directed to you as well. So let's say that you're on one of these drugs or not, but not taking an anti-inflammatory drug, the so-called non-steroidal anti-inflammatories, or NSAIDs. These are drugs that you actually know very well. They're drugs like ibuprofen, Aleve, which you can get over the counter in the drugstore without a prescription, or prescription non-steroidal anti-inflammatories like take Celebrex, for example, or Mobic, or diclofenac, or Voltaren, etc. So these are medicines that can be taken either short-term or long-term, and if you're not taking them already, they can have a role in diminishing flare symptoms of arthritis or enthesitis, for example, or back pain. So some of you may not be able to tolerate these meds very well, especially with long-term use because you have stomachache from them, for example, or you might have other side effects. There's also a bit of a concern about their chronic use because there may be a very, very slight increased risk for cardiovascular events after decades of chronic use. But certainly in the short run, other than the issue of stomach trouble, sometimes if you have a background problem with your kidneys, there may be an impact on the kidneys. But in general, they're pretty well tolerated, as reflected in the fact that they're now, at least 2 of them, are now available over the counter without the need for a doctor's prescription. I might just mention that the dose that is recommended in the over-the-counter version of ibuprofen and Aleve are actually about half of what we would normally use when prescribing these medications before they became over-the-counter. So if you need to, you can actually take a bit more than what is prescribed according to the bottle that you get in the drugstore if you try these medications. If there's any prolonged use, then of course I would recommend that you have a visit with your physician to make sure that it's appropriate for you. Now, I should also mention while on this, and I think there's something also coming up about this, but there are also some topical forms of these non-steroidals. And so there's a gel form that can be applied. These are, I believe they're all prescriptions, so, but I would have to double check that. The next bullet item is corticosteroids. So the usual form of this for systemic treatment of a flare of arthritis would be taking oral prednisone, and I'll come back to that in a moment. But you also have available to you if you go visit your doctor, and let's say you have a flare in a single joint, like a knee, then the doctor is able to inject steroid directly into the joint and quickly and effectively settle down a flaring single joint or two. And so that actually can be a very helpful approach if, say, you're on a background medication but then a single joint or two flares up. You can go in and get a steroid injection to help settle that down. The other thing, of course, that you with psoriasis know about is use of topical steroid creams, which can be used to help settle down a flare of skin disease. Now, there are lots of caveats about use of corticosteroids because of the potential side effects and other factors. So side effect-wise, with chronic use, there can be a variety of issues, including weight gain, elevated blood pressure, high elevation of blood sugar levels, and then with longer-term use, there can be a diminishment of bone density, development of cataracts, and so these are all particular issues with chronic use of steroids. And then I mentioned something earlier that's very specific to psoriasis, and that is we know that when you use a course of prednisone to settle something down, either something related to psoriasis or psoriatic arthritis or an unrelated condition like asthma, that after you take a course of prednisone, especially if it's a little bit more prolonged and a little higher dose, there can be a flare of psoriasis. And I've seen pictures of people that have had, standard psoriasis, and then they take a course of steroids, and then all of a sudden, after the course of steroids, they get a sort of a really more aggressive form of psoriasis, like erythrodermic or guttate presentation, and that takes some work to settle that down. So there's that special caution in people with psoriasis about the use of steroids. Can be used. It's not totally contraindicated, but it's best to be used with caution and often and best under a doctor's surveillance. The third bullet here is something that you may not have ever heard about before. It's called Acthar. This is a medication that's given as a shot. It's approved for psoriatic arthritis, and it can be used in short courses to significantly settle down flaring inflammation. It requires a doctor's prescription. Many physicians may not know about it, and so they may need to get educated on it. It's also, you have to work through insurance companies because of its background expense. But if it's approved, and I've used this medication with good success in settling down a flare of disease activity. Then there is, we come to the fourth bullet, the oral disease-modifying anti-rheumatic drugs, or DMARDs. And the traditional ones that are listed here are methotrexate, sulfasalazine, and leflunomide. I suspect all of you have heard of methotrexate because it's been used for decades in treating psoriasis as well as treating psoriatic arthritis. It isn't a blockbuster drug like the biologic DMARDs, but it can be effective, and so it's a medicine that's used on a weekly basis. It's in pill form or by subcutaneous injection. There are some side effects that have to be monitored for, including the potential for liver enzyme elevations, blood count changes. Sometimes it causes nausea or mouth sore, even sometimes hair thinning. So there are a few issues that you have to monitor that are adverse effects of the drug. It's also recommended that you curtail alcohol intake when using it. So especially some of the college kids who have psoriasis or psoriatic arthritis may find that methotrexate is not their most popular drug. You remember when you were in college. So so that's methotrexate. I suspect many of you know it. So if the person who is having a flare happens to be on methotrexate, but say only at 15 milligrams per week, then that could be tweaked up to 20 milligrams per week or whatnot, in order to see if that can help with a temporary increase of methotrexate to subside a flare. All of these oral disease-modifying drugs that are oral take a little time to be effective. So they're not. If you have a sense that your flare is going to be only a few days or weeks, then it doesn't make a lot of sense to start one of these new for the treatment of the flare. Sulfasalazine is a oral medication that's taken on a twice-daily basis. It can be effective for the arthritis component. It's not used to treat the skin or psoriasis component. And again, it's one of these longer-term oral medications to modify disease symptomatology. And lastly, leflunomide, which some of you may not have heard about. It was introduced in the early to mid-90s in the management first of rheumatoid arthritis. It's a daily oral medication that has a lot of properties similar to methotrexate and can be effective in controlling disease. But again, these are medicines that are mainly used as background continuous medicines, and they're not being used to try to control flare. Then there are the biologic DMARDs that you all have been hearing about, I just want to mention one thing that's not on this list, and that's cyclosporin. Cyclosporin is an oral medicine which can be fabulous in treating a skin flare of psoriasis. We don't really think of it very much in using it for arthritis, but it can be very helpful for skin flare. Okay, that's the oral drugs. Now the biologic DMARDs. So these are medicines which, for the most part, are given as either subcutaneous or intravenous medications. There are a number of them. I do want to mention one other drug that is now approved that's an oral medication, but it's often thought of as like in the biologic category because it's very targeted, and we know what the biology of its effect, and that's a drug called apremilast. And apremilast is a daily medication that is now approved for both psoriasis and psoriatic arthritis and can have efficacy in both. It's a very safe drug overall. There's some tolerability issues with it used early on, like nausea or headache. But in general, it's been a helpful and effective drug for us. But again, because it's somewhat takes a little while, several weeks for it to come on board and be effective, for a few week flare, it wouldn't make sense to start, but it was something to consider if you're having a more long-term flare. Okay, so back to the injected medications. There are a number of them. So there are the anti-TNF medicines. There are 5 of which have been approved for psoriatic arthritis, including etanercept or Inrel, adalimumab or Humira, infliximab or Remicade, golimumab or Simponi, and then the medicine certolizumab or Cimzia. Ooh, that's quite a mouthful, isn't it? So these are the so-called anti-TNF medicines. They can have a very quick onset of action, but again, if we're introducing them for the first time, when a person comes in with a lot more active symptoms, it's really on the basis that we think, okay, the disease is going to be acting up here more for a while, so we're going to institute one of these drugs, or we're going to possibly tweak the dose and frequency of the drug or the dose amount of the drug to try to control the flare. And then there are 2 non-anti-TNF biologic DMARDs that have been more recently approved. One known as ustekinumab, also known as Stelara, that's the trade name, which is approved both in psoriasis and psoriatic arthritis. It's a medicine that's given as a subcutaneous injection every 3 months. And then there is the newer drug called secukinumab or Cosentyx, which is a monthly drug given subcutaneously, which is known as an interleukin-17 inhibitor and has been shown to be highly effective in psoriasis as well as psoriatic arthritis. So we have quite a repertoire of various medicines that have been shown to have disease-modifying effects. That means that they can slow down rate of progression of damage to joints, as well as sort of calming down the overall disease activity and preventing or reducing the likelihood of recurrent flares. And then there are the drugs that are sort of at the top of this list that maybe end up being used more short-term, including the NSAIDs, corticosteroids, and Acthar. Now, that's medications that are specific for psoriasis and psoriatic arthritis. Now, here are a number of other things that are more generic. We've talked about heat and ice therapy. I mentioned that ice therapy, some putting a cold pack or a bag of frozen peas on an inflamed joint when it's fresh, hot, inflamed, and then moving over to heat when it's starting to calm down. Physical therapy may be helpful in home or at the physical therapy unit. Acupuncture has been shown to be helpful, especially for reducing pain, and I know that's something that out here on the West Coast is a increasingly popular and common form of treatment, and meditation. I can't stress enough the importance of reducing stress, of being mindful, of potentially using actual meditation, and this can have a calming influence which may be helpful for flare. Here are some other things to keep in mind, and that is that the drug supply, the health supply stores which have things like braces, or drug stores which have braces and adaptive aids for all of our everyday activities, writing, cooking, walking, etc., can be helped by use of things like these handles for utensils or for tools or writing implements, and also using canes. Bracing is also important, like wrist braces or knee braces. Now, how about stress? We've talked about that a lot. Increasingly, there have been studies over the years that have shown us that there's a direct link between stressful issues that we are dealing with and the potential for flare of an underlying chronic disease. And so managing this either by methods that you have learned on your own to reduce stress and take yourself out of stressful situation, or through the aid of people that are counselors, psychologists, and other behavioral medicine specialists that are really good at helping quiz and interview you to find out what potential stressors are and reducing them in your life by various means, including such things as meditation, biofeedback, and so on. And then just pursuing this a bit more, there are here listed things like art therapy, positive visualization, journaling or just writing, muscle progression therapy, breathing exercises, something called aromatherapy. And there's a link to the National Psoriasis Foundation for getting helpful hints about guiding you to some of these approaches, both in the form of educational brochures, but also potentially guiding you toward practitioners that can be helpful. How about what's going on in research? Well, I've alluded earlier to the fact that Philip Hellawell's group in England is doing research on flare. He works out of Leeds in northern England. Philip is a longtime PsAologist who's current president of an organization that I work with as well, known as GRAPPA, which has to do with research and education about psoriasis and psoriatic arthritis. It's a global organization of almost 800 physicians that are interested in these conditions. And Phil has a special interest in outcome measures, and so he's, first of all, trying to just understand what flare is by quizzing patients, both in individual and group format, to see how they identify triggers of flare and how they can tell whether they're in a pre-flare state, what defines a flare for them, in their unique manifestation of psoriatic arthritis or psoriasis, and then also methods that people use to try to self-manage and control their disease activity. So that's going on. And then there's a lot of research going on with medications, bringing new medications to market and use for psoriatic arthritis and psoriasis, many of which are long-term medications, but some of which may be used for short-term management of flare.
All right, so, thank you so much. So we will start our Q&A session at this point. All right, so we have quite a few questions here from participants who want to know if medical marijuana is an effective tool for PsA flares.
All right, fun question. I'm grinning on this end because guess where I live? I live in Seattle, Washington, which is a state which has actually legalized marijuana, so we don't even have to restrict it to use for medical marijuana. And so I will acknowledge to you that patients of mine do use marijuana in various forms to reduce pain, to improve sleep, and to help relax in relation to disease flare and disease activity. Now, in other states where marijuana is not legal, which is most of the states, there may be legalization of medical marijuana, which is referred to in the question. And those are states where a physician can prescribe marijuana, and there are specific medical marijuana pharmacies where one can go to acquire this and then use it legally. And then there are states where none of the above is legal, and so my comments are not applicable to those of you that are living in those places.
All right, wonderful, thank you. Another participant asks, how can I decipher which chronic illness is causing my flare?
Oh, I love that one. That's a great one. So let's pretend that you're a person that has psoriatic arthritis, psoriasis, and congestive heart failure, where you've got your heart isn't working as it should, and from time to time there's an increase of congestive heart failure symptoms, which classically means shortness of breath, but it also could be a low-grade fatigue. And I can imagine with a mild flare of CHF, a congestive heart failure, that it might be hard to discern what's what in causing fatigue. So then you have to go by other symptoms or signs other than fatigue, like in this case shortness of breath, which would be more of a sign of CHF, or pain, which would be more of a sign of psoriatic arthritis. Now let's pretend that you have a background history of gout. Gout is a condition, an arthritis condition, where crystals of uric acid form in the joint fluid, and the body's white cells reacting to those crystals leads to a painful inflammation that may last a few days or even a few weeks and then settle down. So then that may be harder to sort out. And so what we often, if a person comes into the office with a really painful swollen toe, then we'll do, and they have a background of both psoriatic arthritis and gouty arthritis, then we'll try to sort that out by maybe obtaining joint fluid from the joint to see if there are crystals that are present of uric acid. We might draw a uric acid blood level to tell about this. But in the meantime, we probably go ahead and treat no matter what. And we might give an injection of cortisone into that joint in order to settle it down, or give a quick course of prednisone or nonsteroidal anti-inflammatories to settle it down. Fortunately, some of the medication approaches that we've talked about cross over into the various forms of arthritis. Let's see another example. Let's pick up diabetes, which is a common background comorbidity of psoriatic arthritis and psoriasis. So diabetes in and of itself can also contribute to fatigue. So let's pretend that you've got a flare of diabetes with high blood sugars. So one symptom might be increased thirst because as a result of the and drinking fluids as a result of the high sugar levels, but the fatigue may be hard to discern between is it caused by diabetes or is it caused by arthritis. So a lot of it is going to be based on sort of your gut instincts, but you can be helped by a conversation with your healthcare practitioner, either a physician or nurse practitioner or a physician's assistant, to help try to sort that issue out.
All right, thank you. We have another participant that wants to know if supplementing with collagen is helpful or a good thing to do for flares.
So supplementing with, I presume that what you're referring to is glucosamine or chondroitin sulfate. And so a fair number of people take these products that you can buy over the counter at Costco or in health food stores. And the evidence is mixed on whether it helps arthritis. There's some studies that show that it helps these kind of things help arthritis and others don't. So I think it's sort of, you have to do it as you wish in that regard. I don't really think of these as management of flare approaches. I think of them as more along the lines that I was speaking about the long-term management approaches. Because I don't tend to think of them as really quick-acting compounds like prednisone or non-steroidals. So I'm not as encouraging or enthusiastic about their use in a flare situation.
Okay, wonderful. We have another participant who uses acupuncture to help tame the pain of her PsA, but wants to know if it will aggravate psoriasis, especially if she's customary to the Kettner effect.
Oh, that's a really interesting point. So the answer is yes, acupuncture can help the pain of arthritis, but no, if you happen to be highly sensitive to physical trauma to the skin and get the Kettner phenomenon, which is a flare of psoriasis where the skin has been traumatized, then that's possibly a no-go situation for you. I think the way you learn about that, if you want to, is to actually undergo some acupuncture and see if that does induce psoriasis in you or not, if you're really curious about it. Otherwise, this is an excellent point to be made that in some people they're highly sensitive and may have actual increase of psoriasis in the areas where the needles are placed.
Wonderful. Another person wants to know, what can I do to prevent joints from freezing or fusing during a flare?
Well, I think on that one I would turn to some of the physical approaches that we talked about, including use of ice or heat, putting the joint through passive and active range of motion. What do I mean by that? Passive means that you or someone else is moving the finger or limb around the inflamed joint without your actively doing it yourself, but either you using your other arm or someone like your wife or a husband doing it for you, where you put the joint through a passive range of motion, which tends to be a little less painful than active range of motion. But otherwise, just doing some general stretching, putting the joints through a range of motion, meaning what's the normal range, and putting it through, trying to put it through the whole range. This is again where something like swimming can be very helpful, walking and so on.
All right. Thank you. We have a couple participants who want to know if there's a connection between seasonal allergies and PsA flares.
Which type of allergies?
Seasonal?
Okay. So the answer is yes. In my experience, a person can get seasonal allergies, feel kind of crummy, and have that be a trigger for a flare. So that's a definite yes. It's not always the case, so I can't look at you if you came in and asked me that question and you say that you do have seasonal allergies and now you're curious if this new diagnosis of psoriasis and psoriatic arthritis will be flared by those allergies. I can't tell you that until you've actually experienced it yourself, whether or not it will do so.
Okay, wonderful. And we have time for one more question here. And someone wants to know if there is any over-the-counter topical ointments or creams that can be put on the skin to help with a PsA flare for that redness and swollenness.
Yes. So I mentioned in the talk that there's some anti-inflammatory topical agents, and I apologize that I don't actually know how many of these had moved to, if any had moved to the point of being over the counter at the drugstore. That tells me I should be practical and go and look in my local pharmacy and just take a look at the counter and see what's there. But my guess is that if they're not now, they're very soon going to be various over-the-counter non-steroidal anti-inflammatory products. I think there may be some currently. Then there are the topical analgesic medications, including, for example, topical lidocaine, some of the others, even things, the old remedies like Bengay, may have some therapeutic benefit for you. So my advice is if you're curious and interested and do experience this, then try going to the shelves where these over-the-counter ones are available. Now, a caveat on that is that and I know that I know we're on time at the top of the hour, so I'll be quick. Most of these topical agents only penetrate slightly through the skin. They don't really get down into the level of the joint or the tendons. Some of the newer products that are being developed have carriers embedded within them that can improve this situation and allow migration of the therapeutic agent to a deeper level. And so that's something that would be worthy of your talking further with your physician about some of the prescribed topicals that might have deeper penetrance.
Okay, wonderful. Well, thank you so much, Dr. Meese. We really appreciate you speaking for us and the content today. And if you still have questions, please be sure to contact our Patient Navigation Center by phone, email, live chat, or Skype. I've also included information in the handout section of your panel at the side of your screen. And once you leave today's webinar, you will receive a survey on the presentation. We would appreciate if you can complete that and provide any feedback. And we want to say thank you once again to Mallinckrodt Pharmaceuticals for their sponsorship of today's educational webcast and for making this event possible. And after today's presentation, this presentation will be made available on our website at psoriasis.org/webcast. Thank you to everyone for joining us tonight, and I hope you have a lovely evening.